Okay, let's pick up from where we stopped. We are going to look at the prevention of asthma, and when we say prevention of asthma, we are not preventing the condition, but we are preventing the asthmatic attacks. And our overall aim of prevention is to design a comfortable living or a condition of living whereby these mothers with a positive history of asthma do not go into asthmatic attacks. So let us start when they are children, or if it is a mother, we shall start by vaccinating them with influenza vaccine. Like when they start early, when we start early, we make sure these people with asthma are vaccinated. We shall always be sure that we monitor their breathing and recognize warning signs of an impending asthmatic attacks. Things like slight coughing, wheezing, or shortness of breath should be taken with concern and then handled urgently. Like we've said, let us as much as possible prevent IV corticosteroids. These patients should be able to respond to oral drugs, and we should only use the IV corticosteroids when they are in an attack. So we teach them the early signs, we treat the coughing, the shortness of breath early with oral drugs and maybe with inhalers, and avoid as much as possible using intravenous drug. Identify and treat attacks early, including upper respiratory tract infection, like I've said before. Let us always provide an antibiotic cover with upper respiratory tract infections. Pay attention to increasing quick relief of inhaler use. Here, we teach the patients to use their inhalers, to move with their inhalers always, and we teach them how many puffs, how to give their puffs when they feel like having signs and symptoms which may lead to asthmatic attacks. So let us also involve families. Let us involve the spouse. Let us involve the relatives in the management of these conditions. So this patient should not keep it as a secret that they are asthmatic. The relatives, the husbands should know, and they should know what to do immediately when this patient presents with signs and symptoms. We should also teach them to avoid allergens or triggers. Like I've said in the beginning, that most of them know what brings about their asthmatic attacks. So let them avoid them as much as possible. Being near people who are smoking, food allergens, stress, etc., if they are some of the causes of their asthmatic triggers. And then let us also teach them how the condition comes about and reduce denial. Some of these patients are in denial. They are thinking it is witchcraft. They are saying it is their co-wives doing the causing them to breathe like they are. So let us always talk to them, and they know the pathophysiology of the condition, how the condition can be got, and then we reduce the denial. So I think those are the few remarks, but before we conclude, let us look at some possible nursing diagnoses that can come up if we have a patient or pregnant mother with asthma. So during an asthmatic attack, we have an impaired gaseous exchange, which is related to airway obstruction, which may be evidenced by a decreased saturation of a level below 95%. Like we've said in the pathophysiology, that when there is hyperresponsiveness of the airway, this leads to airway obstruction. And then at the end of the day, this mother will present with signs and symptoms which are evident of airway obstruction like tachypnea and decreased oxygen saturation. So we can come up with such a nursing diagnosis. Then we have an ineffective breathing pattern related to the inflammatory process as evidenced by fast breathing, nasal flaring, or even chest indrawing. We also have an ineffective airway clearance, which is related to the increased secretion as evidenced by cough. Remember, we said in the pathophysiologies that the inflammatory process will lead about edema, airway obstruction, and then production of mucus. Which of the three will lead to airway obstruction? So this patient, due to the mucus produced, will present with an ineffective airway clearance. And why? Because it is related to the secretions and it is evidenced by a cough. Then this mother is also at risk of infection, which is related to the microorganisms which are infecting the airway tract. So we are also having a risk for impaired fetal gas exchange related to maternal hypoxia secondary to asthma attacks. And because when this mother goes into an attack, even the fetus will go into a state of hypoxia. And this will, our fetus will have a risk of fetal gas exchange. That is why some of we have to monitor the growth or the fetal, we have to monitor the fetal life, the fetal state, in order to rule out fetal hypoxia and intrauterine growth retardation. You can come up with more of this, but this can be some of the expected nursing diagnosis we can look at. So after that, and last, let us look at the complications which can come up with asthma. And we are saying that although women with mild asthma are unlikely to have problems, patients with severe asthma are at greater risk of deterioration. The deterioration risk is highest in the last weeks of pregnancy. But when we look at asthma, it is airway constriction. And let us not forget the pathophysiology of pregnancy, that during pregnancy, this mother is having a high saturation of progesterone hormone, of which the progesterone hormone is one of the muscle relaxing hormone. So, in most cases, when these mothers get pregnant, they will have less attacks of asthma due to the progesterone and the smooth muscle relaxations. But we cannot rule out that they cannot go into asthmatic attacks. So we are saying that in the last weeks of pregnancy, usually they present with these attacks as compared to early pregnancy. So the complications which may arise, one is pre-eclampsia, because during an attack there is vasoconstriction. Then pregnancy-induced hypertension, uterine hemorrhage, preterm labor, and even premature birth can be some of the complications. With these few remarks, I submit. Thank you.